Good evening, I'm Joakim Strömberg and I'm honored to give this keynote talk on randomized controlled trials in Dupuytren disease. I have some disclosures. I am the author of one of the RCTs that will be discussed, and this also gives me the opportunity to present the previously unpublished results from the 5-year follow-up of that study later on. And I also would like to apologize beforehand if I failed to be consistent in terminology by using different synonyms for needle fasciotomy and collagenase, but I'm sure I will slip, but I'm sure that you will follow me anyway. So this is my perspective of the different treatment options for Dupuytren disease, and I used this picture in my dissertation in 2018. Ranging from mild symptoms to the left to more severe symptoms to the right. The focus of this talk will be on the central part of the picture, where we're going to compare minimally invasive procedures such as collagenase and needle fasciotomy to each other, but also with limited fasciectomy. There are RCTs within each treatment, for instance on the use of corticosteroids for needle fasciotomy, but the focus will be on randomized controlled trials between different treatment options. And we're also going to have a look at ongoing and planned studies to see what's ahead of us. And I've reached out to the researchers of the most interesting studies that I've found in order to give you the latest update on what we can expect in the future. So let's get started with this landmark study by Hurst et al., which I can safely assume that you're all aware of and have read. It's a great study, and collagenase proved to be more efficient than placebo injections in the cord. It's difficult to overestimate the impact of this paper. It set off a tidal wave of collagenase all over the world, but it also caused a renewed interest in needle fasciotomy. And I will not go more deeply into this study since you all know it quite well, I'm sure. Speaking of landmark studies, this is one of the most quoted articles by Annette van Riesen and Paul Worker regarding needle fasciotomy. It compares needle fasciotomy to open fasciectomy, and the results for needle fasciotomy are terrible. In my opinion, this is one of the most misquoted articles in Dupuytren research, and this illustrates the confusion in definition. What is recurrence? What is a good primary result? And so on and so forth. But these are the results, the recurrence rate stated in the abstract. But however, in the discussions, the authors use the article by Hurst as a template, and if they apply the definitions used by Hurst, we end up with totally different numbers, and suddenly the recurrence rate is less than 25%. Still, the recurrence rate for open fasciectomy is way lower. The last decade has seen an increase in minimally invasive treatment, and I'm going to go into and spend most time about these studies comparing collagenase to needle fasciotomy. And there are 3 randomized controlled studies published this far, to my knowledge. They're all Scandinavian, 1 Danish and 2 Swedish, and all first authors' last names start with an S. And in the following part, I will go into a little bit deeper into each study and also make a comparison between them. So starting off with Peter Scherman's article, they included 96 fingers, and it was a 2-center study, non-blinded, and the inclusion criteria was both MCP and PIP joint contractures, with a total extension deficits ranging from at least 30 to 135 degrees, but no more than 60 degrees in the PIP joint. The minor complications associated with this procedure was that they couldn't find any difference in the rate of skin ruptures, but the patient scored a higher score for collagenase in pain scores. After 3 years, the recurrence rate was 33% for collagenase and 43% for needle fasciotomy, and this was a non-significant difference. And as in all Dupuytren research, the definitions are very important, and they use the definition below to define recurrence. Going over to Skov et al.'s method, they included 50 patients. It was a single center study. It was non-blinded, and the inclusion criteria was a 20 degrees PIP joint contracture without any contracture in the adjacent joints. So this is strictly a PIP study. And the results, as far as minor complications go, is that they found that 93% of the collagenase group had some minor complication compared to 24% in needle fasciotomy group. So it's a significant difference between the two methods. And at 2 years, the clinical improvement was almost significant, where CCH patients fared less well than needle fasciotomy patients. But there was no difference in recurrence rate. And you can see also their definition of recurrence below. In my own study, we included 156 patients to begin with. It was a single center study. I was blinded for follow-up by a physiotherapist. And the inclusion criteria was more than 20 degrees MCP joint contracture, but there was no limit for PIP joints. But the patient had to accept that the MCP was the primary joint to be treated. The minor complications and pain scores show that there was a significant difference in pain, where patients treated by collagenase reported higher levels of pain on the VAS scale. There was no significant difference between the number of skin ruptures, but however, the rupture size differed and was significantly higher for the patient treated by collagenase. And if we look at the recurrence rate after 2 years, there was no significant difference between either MCP or PIP joints. If we look at these studies together, we see that the primary joint for Sherman that was both MCP and PIP joint. They ended up with most MCP contractures. But for Skov et al. Was the PIP joint, and in my own study was MCP joint, which was the primary joint to be treated. And you can see here the number of fingers included in the beginning, and also the follow-up time this far, and the proms used. Now, if we look at the minor complications, we found that both in Skov's studies and my own, the CCH fared worse than needle fasciotomy. And in regards to immediate correction of contracture, there was no significant difference between either of the methods in any of the studies. And correction of contracture at the final up was a little bit significant in Skov et al. You can't say that, of course, but it was almost significant in Skov et al.'s publication. And recurrence at final follow-up could not prove any significant difference in any of the study. So if we look at the difference here, we can find that the minor complications you could also always argue that these are transient and therefore irrelevant. And of course, you could argue that the VAS scale is not really a validated instrument for this. And also, I've dotted the line around CCH faring worse than needle fasciotomy because it was not significant. It was 0.05. But still, none of these studies showed any indication of a superior outcome for collagenase. And now I'm going to just give you the unpublished results in the study, the follow-up 5 years, which my PhD study, Martin Byström, has done, and you can see that there is no difference between the groups at 5 years either. And this is for the MCP joint, but actually all outcome measures are similar in both groups. So, in conclusion, there is no data supporting any advantage of collagenase over needle fasciotomy, and this leads us into the minefield of health economics. And the comparison of costs for treatment are very difficult. I'm aware of that, but these are the actual costs for treatment for the patients in my study, where the blue bar represents the cost for collagenase and the red for needle fasciotomy. You can also see that there's a small green bar to the right, and that indicates the actual cost for the needle and the drugs used in needle fasciotomy. So collagenase was almost 3 times more expensive in my study. This is not an RCT, but it is a economic study regarding the different methods, and they found that treatment with collagenase was the most expensive and led to the highest rate of reintervention. So why do I mention this? Because I'm supposed to talk about RCTs, and that is, of course, because as for now, Xiapex is not available in Europe since 2019. And I'm sure that we have not seen the end of this yet. There are some hope, of course, that there will be a substitute for this, collagenase, coming back to the market. At this time, I would like to point out this article, which deals with the morphological changes after collagenase needle fasciotomy, and we published this in 2017. I would like and this was made on a part of the population in the RCT, and it was designed to investigate the idea that collagenase acts as a chemical fasciectomy. But our hypothesis was that both needle fasciotomy and collagenase disrupts the cord at one point in the cord. So, and we performed this by ultrasound. So we took 19 patients treated by needle fasciotomy and 20 with collagenase, and the radiologist was not blinded to treatment. This is what needle fasciotomy looks like. This is a needle fasciotomy that I did in a patient treated, which I later did open fasciectomy on. This is how the cord disrupts in needle fasciotomy, and this is the finding that we got with ultrasound in 19 of the patients treated with needle fasciotomy and 16 of the patients treated by collagenase, who found one rupture site and only one distance between the different ends of the cord. However, in 4 patients treated by collagenase, it was a lot more heterogeneous. But still, 16 of the patients showed a rupture at one single site. And we couldn't find any differences between the rupture length and in needle fasciotomy or collagenase. So in most fingers, as far as ultrasound goes, there is a single rupture of the cord. Of course, we need further research to bridge the gap between our rudimentary understanding of the pathogenesis involved in the formation of Dupuytren cords. For instance, at 5-year follow-up, we found that 50% in 50% of the patients, the cord had disappeared. So let's go into what we are to expect in the future. We're going to talk about ongoing and planned RCTs. I'm going to start off with this Finnish study. They published their protocol for this 3-armed study in 2018, and it is comparing CCH to needle fasciotomy and open fasciectomy. And I've contacted Dr. Leppinen, and he tells me that all the 303 patients are included, and they're working with a 3-month analysis for now, so we can expect some results quite soon. Also, my Swedish colleague Dr. Nordenskjöld in Lund is performing this study on recurrent Dupuytren disease, where we randomized them to either collagenase or surgical fasciectomy. And Dr. Nordenskjöld tells me that 48 of 56 patients are included this far, but we will have to wait for the results for at least 2 more years. This feasibility trial was published by Professor Davies and co-workers, and it led to a protocol that has been registered. I emailed Professor Davies, and he tells me that this study was supposed to be launched in Great Britain in March, but due to the pandemic, it's going to be launched this winter instead. And of course, it's a very ambitious study. At clinicaltrials.gov, I found this study by Johan Bedredil, who's going to compare neofasciotomy to limited fasciectomy. Unfortunately, Dr. Bedredil has not answered, but I hope that they will be able to finish this study and they will publish in English. And there are also some interesting studies within the treatment options. There's one registered in clinical trials where they randomize patients to hand therapy or no hand therapy after collagenase, and also splinting versus non-splinting after collagenase. And both these studies are interesting. So, finally, the last decade have seen a major shift from open surgery towards minimally invasive treatments, and it's for the benefit of the patients and also for the benefit of the healthcare system, since it's cheaper. But we're still in the middle of finding out which is the best treatment for the patient, and future research will improve our decision making and how to treat our patients optimally. And I would like to thank you very much again, the organizing committee, for inviting me to give this talk, and also you for listening to it. Thank you very much.